Hello and welcome to the topic Autosomal Dominant Conditions in the module Clinical Genetics. In this topic, we will be looking at the definition of autosomal dominant inheritance, achondroplasia, osteogenesis imperfecta. We'll be also looking at conditions like Noonan syndrome, Marfan syndrome, acute intermittent porphyria, and porphyria cutanea tarda. Let's get started. So what is autosomal dominant inheritance? It is the pattern of inheritance characteristic of some genetic diseases. Autosomal means that the gene is in question with located on one of the numbered or non-sex chromosomes, and dominant means that a single copy of the disease-associated mutation is enough to cause the disease. In an autosomal dominant condition, two affected parents can expect 1 in a 4 chance of an unaffected child, 1 in a 2 chance of an affected heterozygous child, and 1 in 4 chance of an affected homozygous child. Achondroplasia is the mutation in fibroblast growth factor receptor 3 gene causing reduced endochondral ossification. There is epiphyseal growth cartilage failure causing normal bone formation and repair, and there's no increased risk of fracture. In terms of features, there will be large skull, normal trunk length and short limbs, rhizomelia or brachydactyly, and macrocephaly with frontal bossing. Complications of achondroplasia include small foramen magnum, spinal canal stenosis and radiculopathy, secondary scoliosis, recurrent otitis media, and cardiopulmonary complications. As for the diagnostics, there's mid-face hypoplasia and frontal prominence, narrow pelvis with short iliac wings, and narrow interpedicular distance. Osteogenesis imperfecta is a rare autosomal dominant mutation in COL1A1 or COL1A2 genes. It results in the defective type 1 collagen synthesis due to decreased synthesis of pro-alpha 1 or pro-alpha 2 collagen polypeptides. Features include growth retardation, skeletal deformities or brittle bones, blue sclera, progressive hearing loss secondary to otosclerosis, and 2 types of osteogenesis imperfecta is present, which is type 1, the most common and milder form, and type 2, the most severe form with lethal perinatally or within the first year. As for diagnostics, DNA test is done, ultrasonography before birth and radiographic skeletal survey afterwards. A bone or skin biopsy is done, and what can be seen is type 1 collagen mutation. As for the treatment, there's no cure available as for now. An intravenous bisphosphonate is given to increase cortical thickness, and surgery is advocated for functional improvement. Noonan syndrome. Noonan syndrome is a mutation affecting the RAS-MAPK pathway. It is an autosomal dominant disorder. Features include short stature, learning disabilities, and pectus deformity and congenital cardiac defects such as pulmonary stenosis, atrial septal defect, and hypertrophic cardiomyopathy. Marfan syndrome is an autosomal dominant connective tissue disorder. It is caused by a defect in the fibrillin 1 gene on chromosome 15. It affects around 1 in 3,000 people and may occur as a spontaneous mutation. Features are tall stature with arm span to height ratio of more than 1.05, high arched palate, arachnodactyly, pectus excavatum, pes planus and scoliosis. Among other features are dilated aortic sinuses, recurrent pneumothoraces, upward lens dislocation, retinal detachment, blue sclera, myopia, and dural ectasia. Unfortunately, DNA testing for fibrillin gene mutations, whilst helpful, cannot exclude a diagnosis of Marfan's because a number of mutations exist. Hence, diagnosis is made on the major and minor features associated with the syndrome. The life expectancy of patients used to be around 40 to 50 years. With the advent of regular echocardiography monitoring and beta blocker and ACE inhibitor therapy, this has improved significantly over the years. Treatment with beta blockers reduce the rate of aortic dilatation and the risk of rupture. Pregnancy is associated with increased risk of rupture. Porphyria is a group of diseases characterized by excess production and excretion of porphyrins and their precursors. They are caused by enzyme defects within the heme metabolic pathway. Acute intermittent porphyria is the defect is seen in the enzyme porphobilinogen deaminase, which is an enzyme involved in the biosynthesis of heme. Precipitants include sulfonamides, barbiturates, and phenytoin. Other precipitants may include stress, infection, pregnancy, menstruation, starvation, and certain drugs. They are more common in females. Presentation-wise, abdominal symptoms and neuropsychiatric symptoms are observed. Seizures occur in 10 to 20%. A range of psychiatric symptoms include hypomania and delirium may be seen. Hypertension and tachycardia is common. Urine turns deep red on standing, and this photosensitivity is unusual in acute intermittent porphyria. For the investigations, urinary porphobilinogen assay is the optimal way to establish the diagnosis. Porphyria cutanea tarda is the most common hepatic porphyria. This condition can be both acquired and inherited. The defect is seen in the enzyme uroporphyrinogen decarboxylase. Classically, photosensitive rash with bullae is seen, typically developing on sun-exposed areas. When exposed to light, uroporphyrinogen generates free radicals that cause blistering of the skin. Lesions heal slowly, leaving scars. Factors that contribute to porphyria cutanea tarda are alcohol, excess iron, and excess estrogen. As for investigations, urine shows elevated uroporphyrinogen, which appears to be pink fluorescence under Wood's lamp. Porphobilinogen is normal. Antinuclear antibodies are frequently seen. This condition is managed with chloroquine and phlebotomy to deplete the excess iron stores that exacerbate the porphyria. We have come to the end of this topic. Thank you.